Hello, everybody, and welcome to another Ask WHO live question and answer session. Today, we're going to be looking at patient care and post-COVID condition. We have with us today Dr. Janet Diaz. She's the lead for clinical care or patient care in WHO's emergencies program, which means she's the lead for clinical care for COVID-19 at WHO. Welcome, Dr. Diaz.
Thanks, Nika. Happy to be here.
And my name is Nika Alexander. I'm part of the communications team. We've got other communications colleagues working on this behind the scenes as well. We have questions prepared, but it's really for you to ask questions. So if you're on Twitter and you want to ask us a question, do hashtag AskWHO. It's what we always use for these sessions. If you're on Facebook or LinkedIn, drop your question in the comments, and we have colleagues who are looking through, and we'll gather together questions and send to us, and then we'll see them here. So, Janet, just to start off, this would be especially for countries where they're seeing a lot of cases, where the healthcare system are overwhelmed. We're seeing that in many countries where the Delta variant, which is a very transmissible form of the virus, is spreading. Sometimes healthcare services can get overwhelmed. Is it possible to care for somebody at home who has COVID?
Thank you for the question. So simply, yes, it is possible to care for patients with COVID-19 at home or in community centers. I think what's most important is that the system has to know if you're having more and more cases, then you make surge plans, and that may mean that some patients are going to be cared for at home. Maybe other patients will be cared for at temporary care facilities like community care centers or community shelters, and then those that are sick and severe still get cared for in the hospital, where all the system is in place to take care of those patients. So yes, you can be cared for at home. Those that should be at home should be the ones that have mild symptoms, or that aren't too sick. And at home, the important things is that you rest, that you try to maintain your nutrition, that you eat, that you practice IPC, so you're not close to the other people in your house that you're sharing the house with, so you maintain your distance, you open the windows, you wash your hands, you cough into your sleeve or with a tissue, all those things to prevent, you wear a mask. So you don't, infect others that you're living with, right? So I think that's the most important thing. And that you monitor yourself. So if you have any inkling that you're getting a little bit more sick, that your breathing is getting a little bit more troubled, that you're feeling too much fatigue, that you're not getting better, then you have to have contact numbers for your doctor, for the hospital, for the health system, for the community health worker, whichever that person is in where you live. And call for help, because some people may get worse, and if you get worse, then you want to know quickly so you can go to the hospital. And one of those devices we use is that pulse oximeter, right? And so for some patients at home, this is a really important tool, because you can put it on your finger, you can monitor your oxygen level, and then talk to your health provider about what numbers you're seeing and if you need to take any other steps.
So we're not going to go into too much detail on that topic unless we get a lot of questions, but Dr. Diaz and I have done a whole Q&A live on this. It was several weeks ago, if not months ago, but if you go into Facebook, you can look at the old live Ask WHOs, and you can find that previous session where there's more detail. We talk more about the fact that most people don't need to go to the hospital. Most people can be cared for at home, and then in a situation where the healthcare centers are even more overwhelmed, how to make that decision about who stays home and who goes for care. Dr. Diaz touched on that a little bit this time, but we talked about it more the previous time as well. We wanted to talk a little bit, promote the webinar that you have going on tomorrow. Let people know, because it's public. People can join if they're interested.
Yeah, thank you for reminding us. So we do have a webinar tomorrow. It is on models of care. So this is models of care for home-based care and for community care. And we're going to have specialists and experts from many different regions of the world describing what was done in their settings in order to be able to take care of those when they had the increasing numbers of patients, but to do so safely in the community or at home.
So it's open to the public. It's not really information for the public to use, but it might be quite interesting to learn that such and such a country. Well, do you have some examples of what countries
So we will
be
have
joining?
Experts from India, from Indonesia, from Kyrgyzstan, from Colombia, and those are the ones I remember off the top of my head.
So if you are interested and you want to join the session tomorrow, I think we've tweeted out information on that, so you can go and have a look, and our colleagues might be dropping that information into the chat for this session as well. But you're welcome to join and learn, as we do at the same time, what some of those models are for making sure that there's systems for caring for people at home as well, for even ones who are a little bit more sick than you might normally want to have cared for at home. Just another question. People often wonder why there isn't a cure for COVID. The vaccines were developed really quickly. We often talk about what an incredible feat of science that was. And at the moment, there are a few treatments for COVID, but there's no cure. So just talk a little bit about that. What's the difference between a treatment and a cure, first of all? Because some people might think, well, those are interchangeable.
Well, it's a good question. I think for understanding this infection and this virus, we know first the virus enters the body, right? But in some patients, and that causes some symptoms, right? Let's be it a cough or you lose your sense of smell, right? It causes a symptom. But in some patients, the body, as it's trying to fight the infection, as your body does for any infection, there is, in some people, an abnormal immune response. So the body wants to fight the infection, but then it's fighting too much, and it's causing this immune response, and that causes more sickness. So if that makes sense, because it's a little bit, so when it's
well calibrated, when your body's fighting the threat at just the right speed, that's when you feel better quickly.
Yeah.
But if your body's overreacting in some ways, that can have these knock-on effects, a domino effect, and you feel worse.
Yeah, and that causes injury to your organs. So what happens in your lung, maybe the virus is in the lungs, but if it causes an abnormal immune response or an inflammatory reaction, this is the medical terms, then that itself can cause damage within the lungs, and that can cause not just in the lungs but also in the brain, in the kidneys, when you start to develop different systems, multi-systems, organs that stop working, and those people can become quite sick. So in treating, when we think about cure, you're wondering, okay, can I just give you a drug that gets rid of the virus?
And then you're done.
But we don't actually have that, but we have treatments right now that help you kind of control this abnormal immune response if you develop it, and that itself, we do have treatments for that. And in general, we have care plans. So even though we may not have the pill, the cure, we have care, and we can care for you when you have COVID-19 with different interventions depending on what how the disease is in your body.
So that's why I think we've seen from the beginning the mortality rate in very, very many countries has gone down. So of X number of people who are under care, fewer people as a percentage die, as we've learned all together what works in order to treat COVID.
Exactly.
Yeah.
So the care, and I think at the beginning too, because it was so new and the systems weren't ready to care for so many patients, that the hospitals got too full, and during those times it was very difficult to manage the patients. So now we do know the best supportive care, how to treat the complications of COVID-19.
So there isn't a cure. The idea of a cure would be the minute you are tested, you realize you have COVID or you have the virus, to be able to take something that would make the virus disappear. That doesn't exist, but there are drugs and approaches that help care for someone who is sick with the disease, depending on how they're presenting, what their different symptoms are. So we have a question from, there seem to be a lot of names, I'm not sure I'm getting this right, but Dezeen Kenneth, who says, in case of treating patients with COVID, what are the drugs used at the moment? So you touched on it a little bit, but here's a chance to go into a little bit of detail. So what are the tools we have at hand?
So the tools we have now are the ones that WHO recommends at this moment, are the ones that we use for patients who get very sick with COVID-19. So those are the patients who have severe pneumonia or progress to have respiratory failure. Those drugs, one is oxygen. So oxygen is a medicine, so that's a number one point. It's a life-saving medicine. So patients who develop COVID-19 with severe pneumonia should be placed on oxygen and be monitored. That's number one. Number two is a drug, an old drug that's widely available and cheap, and that's corticosteroids. So those are can either be taken by mouth or in an IV And those are immunosuppressants. So those are anti-inflammatory. So this abnormal immune response that I spoke about, you take some of those pills and it controls it. And what's nice, though, is it's not a high dose. It's a relatively low to moderate dose. And it's not a long course. It's actually, just a course to get you through the worst part. And when you take those drugs with the oxygen, your life, the reduction in mortality, we have seen that dramatic reduction in mortality, and also the need for going on the breathing tube, the ventilator, the respiratory support device.
Less needed.
Less needed. So we do recommend that for those patients. And then most recently, we have a new drug that we have as a tool, and these are called IL-6 antagonists. So again, IL-6, which is a molecule in the body that's part of the inflammation, and in patients who have severe and critical COVID-19, if you have high levels of this, it's associated with a higher risk of dying. So this medicine actually blocks that activity. So when you give this medicine, in addition to the corticosteroids, we also saw a reduction in mortality and a reduction in the need for the breathing support machine.
So just before we move forward, though, one of the things that I remember when we rolled out the guidance on the corticosteroids is we were very clear that it has an incredible positive impact when used at the right moment. And in fact, it could be a negative impact if it's used too early. If it's used on people who are just starting to feel sick when their body is actually fighting the virus, it could be dangerous if you give them an immunosuppressant, right? So who are the people that doctors and nurses should be, what type of patient benefits from having corticosteroids?
So this is a key point here, because what we don't want is people who are just mildly sick, with a cough and a fever, not with normal oxygen levels. We don't want those people taking corticosteroids, because actually we were concerned that those patients may actually get worse on the corticosteroids based on what we saw. So first is really the respiratory status and the respiratory condition. If you have a oxygen saturation that is low, so that means you have a pneumonia or severe pneumonia. If you have severe respiratory distress, so those are the kinds of patients that would get corticosteroids. So it would not be for the outpatients that have mild symptoms. So that's it. So it's the right time, and you don't want to take too much. We also heard that some people started taking, like before and during the episode, taking higher and higher doses. And since it's a immunosuppressive, actually you do need part of your immune system to fight the infection.
You don't want to shut it down completely.
No, and if you shut it down completely, not only is it bad for the virus infection, then you can be predisposed to getting other infections.
That your body was managing.
Yeah, and
before.
So this can be very complicated, like a fungal infection. Let's say you have diabetes, which is a risk factor for COVID-19. Diabetes also may weaken your immune system if it's not controlled. And then you take too many steroids, and maybe you're not even supposed to be taking them. So that can really complicate. So it must be done under medical supervision. Your clinician, your doctor, your nurse has to understand, are you the right person to take it, when to take it, and to monitor it.
Okay, so that answers. We have this question on Facebook from Jane Alam Riaz Sohaila Alam. When should you use cortisones or corticosteroids? But then the same person is also asking, when would you use Remdesivir and when would you use antivirals? So let's start with Remdesivir. Does WHO recommend Remdesivir?
So actually we have a conditional recommendation. So that's a recommendation to not use Remdesivir. The reason we have that is that when we did the evidence analysis, it was not clear with strong certainty. So we were not certain that the mortality benefit was there, or even that the clinical benefit was there for reduction of hospital days. And that was taking all the trials that had been published. And so that was a conditional recommendation. And that means sometimes we have strong ones and sometimes we have conditional ones. The strong ones means that we were very certain, and this is what we think you should be doing. The conditional means we weren't so certain, so we still advise against it until there's more information. So WHO is not recommending for the use of Remdesivir. We're closely watching, though, the evidence as it emerges, more trials to see. And there are not any other antivirals that we have found yet that are effective, but we are looking. There are some drugs in pipeline, meaning they're in production, they're in studies, oral antiviral, so that we are hopeful that that one of these may show benefit, but it has to be tested in a clinical trial before WHO would recommend it.
Okay, so this is more not a question; it's more like showing that they're listening. Zimbili Shezi says, so the treatment would be some agent that modulates the immune response. That's essentially the kind of treatments we see are ones that help control the immune response. Is that right?
Yeah, that's correct. And so there's others that are also being studied, other types of immunomodulators, which is a good word, in addition to the IL-6 receptor antagonists. There is other families of immunomodulators that are in clinical trials. And, we do expect to hear results from some of those additional trials relatively soon. So we'll keep you updated.
Okay, so we said we wanted to touch on treatment, patient care off the top, so that's what we've done. And now we have a fair number of questions on long COVID or post-COVID conditions, so let's skip to that. We have a question from Juliana Benz, who's asking, what are the most common post-COVID health issues? The immediate ones and then the longer-term ones.
So thanks for the question. And things are evolving over time, but actually we are starting to see quite a few publications and reports, more and more. So I think it's most important that everyone is collecting this data, that patients are active in research in order to understand better post-COVID condition. What it appears to be is usually is a multi-system disorder, which meaning that people have symptoms that are affecting different systems. Some of the more common ones that we have observed are shortness of breath, right? So people feeling short of breath after their acute COVID-19. Fatigue, so people feeling extreme fatigue that lasts beyond the acute episode. And then some people experiencing cognitive dysfunction, which is brain fog, as people, and that it can be interpreted more like maybe difficulty concentrating, slowness of thinking. And so those are three common ones, but to be honest, there's been over 200 reported symptoms. Others can be like chest pain, neurological tinglings, new rashes. So there are various reports that we need to better understand, but those are some of the three. And the symptoms seem to be of either like they persist. So you were sick with acute COVID and then the symptom didn't go away, didn't get better. Or that some people are describing relapsing, like it gets better and then it gets worse, and then it gets better and it gets worse. And so you think you're better and then it comes back. And other people are saying some symptoms actually I didn't have during my acute episode. It started after, but I think it's still related to this.
So there's a real range. On Facebook, we have a question from Selena Chowdhury. She says, I'm one of the fortunate survivors of COVID-19. Well done, Selena. Please tell me the duration of post-COVID symptoms such as, and she's listing some, presume that she may have experienced as well, depression, body pain, headache, and so on, or maybe not, but thank you for asking. So you said there's different models or different situations that we've heard reported. Some people, it's like a long tail, and other people it comes back and forth, but do we have a sense of the duration?
Well, I think it's too hard to say, and I think we'd have to continue to do these studies over time. We're about 1.5 years into the pandemic, so at most we followed people, out a year.
For 1.5 years, yeah.
Right, so there is the early studies from China that are following people out. So I think we have to see, but it's been reported 3 months, and then people duration, and then people resolve and get back. Others at 6 months, and then get better. But we are concerned there may be a small proportion of patients that maybe go on to 9 months and to longer than that. So we'll have to see.
So Selena, I hope you don't have the long-term conditions. On LinkedIn, Christina Troyer is saying, what role do you feel rehabilitation plays, physical, occupational, speech therapy, in recovery from COVID?
So I think rehabilitation is a key intervention throughout the entire period of COVID-19 if you get infection and you get disease with COVID-19. in the hospital, let's say you get severe pneumonia, you're in the hospital on oxygen, having a rehab intervention and care by a rehab team is important to ensure that, there's not what interventions can be done inside the hospital or inside the intensive care to optimize your recovery time, to optimize your functionality after you get out of the hospital. And then out of the hospital, if you are one of those people that has post-COVID-19 condition or long COVID, more prolonged symptoms, then the care should be multidisciplinary and should include rehab professionals in the care plan to help speed through recovery and get you back to functioning the way you want.
And I'll cluster my question with this next question. It comes from Twitter. Hard for me to tell who it is, but I think the last name is Sulani, wanting to know what guidelines there are for long COVID. Has WHO developed some guidance or some sort of summary of knowledge so that healthcare workers know how to care for someone who's experiencing that long tail of symptoms?
So we still have a bit of work to do on this. So we put out our initial long COVID guidelines in January of this year, and those were very early. So they're guidelines that say that this exists. You should monitor and make sure you set up your care systems with different specialists, right? In case, depending on which symptom you have, you may need a different specialist or different type of diagnostic test. So we did put that out, but we do need to put out the next version of that guideline. So that's something to be coming. We also have been conducting webinars. So we had our second webinar last month, and that is on the website, so we can access that. All the lectures and the speeches were all recorded, and you can access that and learn more about what we learned at that webinar. We'll be having another one on rehab coming in the fall, so stay tuned for that one, which will focus on rehab and care models. And then some of the more scientific work we've been doing at WHO is trying to finalize the case definition. We're doing that with many different stakeholders, including patients, the important stakeholder in this, and we do hope in the near future to have that information for public use.
I suppose someone, we'll see if our colleagues can drop in a link to that older webinar you mentioned, but otherwise I suppose if people just search WHO webinar, at the time were we already using post-COVID condition as the language? Okay. A question from Facebook from Benli May Kuraza Calabia. Can post-COVID patients still infect other people? So you've recovered from the severe part of the disease and you're having some symptoms still. Does that mean the virus is still present in you, and can you pass it on to someone else?
That's a good question. We don't think you can pass it on to someone else in the post-COVID condition period, right? And so if you have it, we don't think you can pass it on, because at that point you're beyond the acute illness. You've likely cleared the virus at that point. And then you're asking why, though, did I get it? And so the logical, the thing is, we don't fully understand that yet.
Why you have those symptoms still.
After. So is it some neurological problem, or is it an immune response? So remember I told you before that the immune response can cause a severe manifestation, but is there something with the immune response that actually may cause the long COVID symptoms? So that's another hypothesis. Is it a coagulation problem? We also know blood clots are a complication of post-COVID. Is that happening in the long COVID patients? And then some people have talked about virus persisting. Is virus in some of the organs? And that's also a hypothesis. But we have lots to learn in order to better understand. But you're not infectious with post-COVID condition.
As far as we know.
As far as we know.
And how do we learn that? How do we go about collecting all the information that health workers around the world are gathering, all the information that patients are sharing? How does WHO gather that? What's the mechanism? Well, gather and analyze it, I guess.
It's kind of complicated. So we have different ways to gather information. What we rely on mostly is that academicians, patient-led researchers, all these stakeholders are conducting research. And so what we do is then review the literature. So we have teams that, do reviews of everything that's been published, everything that's in preprint, and do an analysis of all that's out there to kind of understand, what is true, what is not true, what may be true. So we constantly are reviewing the literature, putting it together in a meta-analysis or systematic review, and then using that to make our guidelines, our policy. In addition, WHO also has on our website standardized data collection forms. So for example, for post-COVID-19 condition, we have a standard data collection form that your doctor or care provider can use to fill out, what symptoms do you have, what testing did you have, all these things. And when you do that at a local level, national level, then you can understand better the
you can see patterns.
You see patterns. And so we strongly support standardized data collection of patients with post-COVID-19. And we did the same thing for acute COVID-19, where that's what helped us understand the disease.
So you have that's data out there, but I know you also bring those experts together and speak with them. There's the webinar you spoke about, but before you get to doing a webinar, there's also these networks that you meet with on a regular basis, and I imagine you go into each of those calls with some questions, and then you discuss them, right?
Yeah, so the clinical network has been convening since the beginning of the pandemic, and that really brings clinicians who are caring for patients with COVID-19 together to kind of share their experiences and their observations. And this has been going on. We actually had one called today to discuss certain things, and that's the way we've been able to know kind of real time what's happening before the publications, right? Now there's many publications because it's been a while, but at the beginning that was really an important source of information. For post-COVID condition, we are convening a group of experts right now with stakeholders every 2 weeks, and that work is focused on a core outcome set, and that is a research tool. So we're trying to develop a core outcome set, which is a survey. We'll go out to a survey to clinicians and experts from around the world and patients to standardize how clinical trials should be done and what outcomes should be measured, and that we hope will help expedite the trials that will be done for post-COVID condition and treatments and interventions.
So we've been saying, instead of long COVID, we've been saying post-COVID condition. Why is it that we make that distinction? Why don't we call it long COVID? And in fact, over time, I've heard you start to use post-COVID condition more.
Yeah, I think from WHO perspective, the naming team here, which we have a group that focuses on names, they named this in September of last year. The reason they did that was because the reports were already coming out, and they thought that was the best way to describe something that we really didn't know anything about. So we wanted to be recorded, right? So it's an ICD-10 code. It's a code.
That's
so
the International Classification of Diseases, ICD.
Yes.
Mm-hmm.
And so we have that code, so that means it could be coded in medical charts, and that's good, right? So they did that because it seemed at that point that we needed to make a term that was broad enough not to exclude people because we just didn't know. It could be over time, maybe after a year's worth, that we relook at the name once we understand it, and can we be a little bit more specific. But right now, I think from our perspective, we wanted something that was broad, that would encompass, this condition. So that's why the team chose that.
Okay.
With experts, of course.
I think we're going to wrap up shortly, but I just have a couple more questions. If you do have a question, though, please drop it in quickly on Twitter. You would use hashtag AskWHO, and on Facebook and LinkedIn, you'd put your question in the comments. And I'm speaking today with Dr. Janet Diaz. She's the clinical care lead in emergencies at WHO, so she's basically the lead for COVID treatments. So I'm going to step back actually and ask you a few more questions on treatments that came in a little bit later. One of them is Ivermectin. So Andrews Boissiere is asking, when is WHO going to take a closer look at Ivermectin? In fact, we have.
Yeah, thanks. It's an important question. So we looked at Ivermectin in the month of March, I think is the publication date of that guideline. And we did take a very close look at the data at that time. And we came out with a recommendation that ivermectin should only be used in the case of clinical trials. So we did that because the data, when we looked at all the data, there was too much uncertainty about everything impact. And we thought that it was important that if it's going to be used, that it be used in trials, and that would generate more evidence. Mm-hmm. And then we can take another look at it. So we'll be looking at, we actually are always we work with again, our partners. We have a systematic review team that's always looking at publications, and that gets updated on a regular basis. So it's on our radar, and once we see enough data, more data come in, then we may adjust the recommendation.
I mean, it's a little bit controversial. There's some countries that are quite positive towards ivermectin, and people will see a study where it looks like there's a good signal, and so wonder why we're not following that particular study. But as you're saying, we look at everything as a whole, put all those pieces together, and there's no clear indication of it being helpful, but we're recommending that it still be used in clinical trials in case something can be found later, essentially.
Yeah, and I think so. I think every drug you can take you do it because you think it may work, right? But it also has its risks. So WHO does not want people using drugs that have no proven benefit. The risk of using drugs with no proven benefit is actually you could take a lot of different drugs and they can have side effects, and those can be very concerning side effects. So we've chosen the approach that we, once generate evidence, do the clinical trials, and we will look at it quickly and write recommendations, but don't use drugs or medicines that have no proven benefit, because they may cause more harm, and that's what we want to avoid.
We have a question from earlier as well from Dr. Humphreys, Campila, and Sona, who wanted to know, and this was from earlier when we had been talking about some of the medications that were positive and were helpful. Dr. Nsona wants to know, where can these drugs be sourced, or are they available in Africa? Some yes, some no.
Great question.
Some more easily than others, I suppose.
So WHO is committed to try to improve access and availability to life-saving treatments for COVID-19, period. One of the ones that have been most visible in the media has been oxygen. So we do know some countries have lacked sufficient resources in oxygen. So that is something that we are committed to in improving access to. Again, there's a lot of information about our oxygen scale-up initiative on the website. Corticosteroids are widely available. Those are very cheap and should be available in all jurisdictions. So if there's low middle income countries that feel they don't have access, please go to the UNICEF supply website, and they do have information about accessing corticosteroids. And then the IL-6 antagonist, that's the most recent one that we wrote the recommendation. There, we are trying to work with manufacturers and other partners in order to make access and availability, and also a cost that would be reasonable for low and middle income countries. So that is an active piece of work, and I think we have to do more for the IL-6 antagonist, but that's something that a lot of us are working on right now.
Tell me a little bit more about the oxygen. I find it really fascinating when you present at these weekly meetings that I join in as well, where you've talked about the kind of really concrete work that WHO has done, going as far as helping countries design sort of the manufacturing of oxygen. So helping countries concentrate oxygen locally so that you don't have to ship it in, but it can be produced locally. So can you talk us through one of the countries where we've done that? I know it's been in several, and what you have to do to get that system up and going in a country that doesn't already have a good supply of medical oxygen.
So the oxygen limitations, has been problematic in multiple countries, unfortunately, a chronic problem before COVID. And COVID obviously exacerbated it. So one of the interventions we first did is, procurement of these little oxygen concentrators. So those are small oxygen concentrators that can serve one person at a time, one patient at a time. And that has been a steady intervention by WHO and other partners since the beginning of the pandemic. We also then got involved in supporting countries to develop the bigger oxygen concentrators. So this is like a plant now that can serve, a mid-sized hospital or large-sized hospital. And those are sized according to how many beds and how many patients. And they're configured based on what the hospital wants. They can either just sit in one hospital, or they can be moved from one hospital to another hospital. And so there's a lot of technical questions, technical specifics about this. So WHO, with the biomedical medical devices group here, has been giving advice to ministries of health. And we've been trying to build the workforce, because it is a workforce that needs to increase, that meaning biomedical engineering workforce around the world, to work with the clinicians in order to be able to give this medicine, which is oxygen. So
It's not something that I could just start doing tomorrow. I mean, it's a skill. You need
it's a
specialization.
skill, and it's equipment, and you have to buy the equipment, the technology, and then you have to operate it, right? So you have to know how to operate the plant and how to move the oxygen, fill the cylinders,
Troubleshoot when something goes wrong.
and so all that package of stuff is what the work WHO has been doing, again, with its with multiple partners out there.
Can you name a few countries? You have them off the top of your head?
Yeah, so right now we're just about to finish some work in Chad. We've been supporting Guinea-Bissau, Somalia, so countries, many countries around the world.
I put you on the spot.
I know.
I can never do lists when I'm put on the spot, so I'm sorry for that. So we're going to wrap up, but one good wrap-up question from Joel Sunga on Facebook was, can you repeat the list of medicines that WHO recommends for treating COVID?
Okay, so for patients who are severe and critical, that means you have progressive pneumonia, so oxygen, corticosteroids, either IV or by mouth, and these IL-6 antagonists, which what's called tocilizumab is one of the names of those drugs.
So those are meant to be used under medical supervision, ideally in a hospital. In some conditions, maybe it can be supervised remotely by a health worker. What is something a person can do for themselves if they're not so sick that they need to go to the hospital or be under the care of a health worker, but they have a terrible headache or they're feeling all blocked up and uncomfortable? So that's not the same thing as, treatments, not the drugs that have that big effect on your body if someone's quite sick, but what are those symptomatic treatments that people can administer themselves?
So for fever, just like you would do from another virus that may give you a cold or muscle aches, fevers, you can take paracetamol. So that's a simple medicine to take, and that should help you symptomatically feel better during this time. Rest, like you do when you get some sickness from other things. Try to stay hydrated, try to eat something, don't stop eating, take care of yourself, and check in with your family, make sure that you're not all alone. You should be connected to maybe not physically because of the
Physically distanced, but socially connected.
But socially connected, because you don't want to get, depressed or anxious if you're having this and I think that's an important part of it. And then, rehab, even if it's at home, you may be really fatigued and maybe, winded or, get tired easily. So take it easy for the first few days, but try, pace yourself and try to get back to your activities. Don't overdo it. But those are the sorts of things to deal with at home. And then if you really just feel like you're getting worse, cough is worse, breathing is worse, the pulse oximeter is worse, then you call for help.
I think that's what people can find a little bit mysterious about this disease, is it can range from no symptoms, so you don't even know you have the virus in your system, all the way to being quite sick, needing hospitalization, and some people even die. So it's sort of hard to wrap your mind around how can the same virus cause such a huge range of effects, but that's just what we've seen, right? All right, so I asked myself a question and I answered it myself. So the countries where you've been watching us from today are Barbados, India, the US, Ghana, Nigeria, France, UK, Sweden, Madagascar, Indonesia, Armenia, Nigeria, Angola, Tunisia, Spain, Netherlands, South Africa, Iran, Sweden, Philippines, Kenya, Cambodia, and some others that I didn't say. So thank you very much for tuning in today. A few things that Dr. Janet Diaz mentioned. There's that webinar tomorrow on countries' experience setting up systems to look after patients remotely, so in the community or even at home. So have a look on our social media channels for that. You can go backwards. You can look back for the webinar that was on Rehab that you said was in the fall. Oh no, that's coming up in the fall, so keep your eyes out for that. There's other webinars on post-COVID condition. My name is Nika Alexander. Thank you so much for watching, and thank you for all our other colleagues who make this happen. Have a good evening, have a good morning, have a good afternoon, no matter where you are. Be safe, take care of yourself, and take care of others around you as well.